very, very much for inviting us. I forgot to put the conflict of interest slides in there. We have no conflicts of interest at all. So we have three objectives in this presentation. We're going to review why family caregivers are important, how we should support family caregivers, and then talk about our initiative, Caregiver-Centered Care Education for the health workforce, to provide person-centered care for family caregivers. So family caregivers are often referred to as the shadow or invisible workforce. 25% of Canadians are family caregivers. In the community, family caregivers provide 70 to 90% of the care for people needing care in the community. And pre-COVID, we're assisting with about 10 to 30% of the care in long-term care. Family caregivers provide 10 times more care than paid providers. In 2009, Marcus Hollander calculated that the family caregivers contribute about $26.5 billion in unpaid care yearly. Using the 2012 statistics from the General Social Survey, Statistics Canada, Janet Fast, an economist from the University of Alberta, values that contribution at $66.5 billion per year. You often hear about family caregiver burden. However, anxiety and distress are better measures to connect with well-being, as you probably know. Feeling lonely is linked to the risk of depression, dementia, poor self-rated health, and premature mortality. Loneliness carries the same risk to health as smoking 15 cigarettes a day. It's twice as harmful as to health as obesity, and the premature risk of mortality is as lethal as alcoholism. So anxiety is the most frequently measured psychological disorder among family caregivers. It typically rises as care responsibilities increase and energy is depleted. It's related to heart disease, dementia, and premature mortality. Both loneliness and anxiety are rising in family caregivers. So the statistics here for anxiety, 16% in 2010 come from CIHI. It was 33% in both BC and Ontario. That was, again, Health Quality Ontario in 2016. And in our survey of family caregivers in July of 2018, this is Alberta family caregivers, and it's similar in BC family caregivers, and Manitoba's just doing the same survey right now. It was 54%. So that's in July of 2020. And again, the same thing, about 35% for loneliness in 2010, 46% in 2016, and it was 85% in the caregivers, the 604 caregivers that we had in our survey of family caregivers in Alberta. Why are loneliness and anxiety rising, and particularly since the COVID pandemic? There's fewer family caregivers and they're caring for longer, and you saw that stress increase as we suddenly had one essential family caregiver. But just generally, there's smaller families, women and men are employed, there's more separations and divorces, so children are not living in the same area. And that's particularly the case in rural communities. There are more older people with more chronic conditions, and medical advances mean they live longer. The people that are caring at home are caring for an average about 6.5 years now. There's also a push to age in place. Canadians want to stay in their own homes for as long as possible. It's over 90% of them. And there's fewer long-term care beds. So distress, loneliness are quite common. Now, it's really important here to recognize what's stressful. Like a doctor, or nurse, or physiotherapist, or social worker, people find caring for others rewarding. But care work becomes stressful when you're overwhelmed with work and worry. So caregiver distress rises when they are providing more than 20 hours of care weekly. The care receiver lives with them, which usually means that somebody requires more complex care. The receiver has moderate to severe impairment, depression, cognitive impairments, depression and responsible behavior, and the caregiver is providing medical treatments. The defining feature of family caregivers is diversity. Rural, remote, urban, suburban, caring for people of all ages and very different conditions. As this slide shows, it can start with sporadic care, something like a bit of shopping or some driving, but like stroke or cancer, it can start out with lots of personal care and lots of support being needed, and it can go with cancer or stroke, it can go to long-term care admission or palliative care, or it can get better. The trajectories with dementia or heart disease can be quite different. It can start out with sporadic care, expand to activities of daily living and health supports. It can reduce a little bit as home care starts. As it expands to personal care, it increases long-term care admission. It may decrease, but remember as well that even at long-term care admission, family caregivers are still spending a lot of their time in long-term care. So Jasneet's going to take over here at this slide.
Thank you, Sharon. And again, apologies for not adding a conflict of interest and disclosure slides. And under disclosure, I'd like to add that in the last couple of years, we've received several grants for this work. One is the CABI Spark grant, another is an AHS Seniors Health SCN grant, and most recently an Alberta Health grant. So I'd like you to reflect for a moment and consider what our general practice in the healthcare system has been for the last decade or so. As we have required family caregivers to provide more support, our tendency in the healthcare system is to ask family caregivers to do more and more. So there's been an increasing shift of care onto family caregivers, particularly as we've tried to reduce the demand for acute care hospitalizations, tried to reduce the footprint in long-term care, and enhance care in the community. This is meant to sustain care. What we've forgotten during this well-meaning healthcare imperative is that we are actually increasing the care burden on family caregivers, and we are not looking out for their health and well-being. And we really have not done any judicious, deliberate, thoughtful planning around how to support family caregivers. So this slide is to just have us consider that we should be seeing family caregivers for their knowledge, for the care they provide, the monitoring they do, the navigation they assist with as partners in care. We need to engage them respectfully, and we've got to think of them more as colleagues in care who require information. They may require some training, but they also require care and they need our support. Next slide, Sharon. We heard a family caregiver in one of our symposia stand up and say, you need to stop building a better caregiver. You need to build a better system to support us. This was an aha moment in our journey in this work. We recognize now more than ever that a wide range of services and supports are required to support these diverse family caregivers along the entire care trajectory, which Sharon so nicely shared with us. And we need to come together as researchers, government, community, educators, and the healthcare system. Healthcare system has to be part of this wider system. We have a responsibility towards family caregivers, and we need to look to see what is it that we can be doing to support them. Next slide, Sharon. We began here, I'm using the word royal we because we've had over 400 multifaceted stakeholders now involved in this journey. And for us, this journey began in 2014 for this group of multi-stakeholders. Personally, I became a family caregiver in 2013 when my parents immigrated to Canada, and I saw my mom providing 24/7 care to my dad. And we supported him for 8 years at home till he finally passed away after a very short spell in long-term care. That was the first time I recognized as a care of the elderly physician how much I had used the family caregivers to care for my patients. I realized I really was not focused on them till I didn't suffer the pain of being a family caregiver. And I did the caregiving just like Sharon said, willingly. It was very fulfilling, very rewarding, but along with it came a lot of grief and stress and burnout. From there on, I said to myself, what is it as a care of the elderly physician who relies so much on family caregivers? How is it all these years of practice, close to 20 years of practice, I never stopped and asked a family caregiver how were they doing? It never occurred to me. And I met them daily. And you know, if you're in geriatrics, you are interacting with family caregivers in every setting, acute, rehab, outpatient clinic, outreach teams, primary care, home care. You're interacting with them all the time. And I'm thinking, here I thought I was doing such a good job in informing them, telling them what to do, what to monitor, to report to me, carry out my instructions, but I did never stop and ask them, would that be difficult for them? Do they have the resources to do it? How are they managing? How are they coping? How are they doing? This journey has now, after 7 years, brought us to this point where today we can share something really exciting with you. But literally from 2014 on, with the help of these stakeholders, we had to shake our healthcare system up. And we had to say, look, let's get together and explore what are we doing. It took us 2 years to do that. And we realized we weren't doing very much at all. But in the process, we collated all the issues family caregivers were encountering when they interacted with the healthcare providers. And then in 2018, we followed through with a major recommendation, which was we've got to use this missed opportunity where healthcare providers interact with family caregivers. That opportunity has to be used to support family caregivers. And that we have to educate our healthcare providers to support family caregivers. In 2019, we validated a caregiver-centered care competency framework to educate healthcare providers. And by caregiver-centered care, we simply mean person-centered care for family caregivers. And then we co-designed the work in 2020. And I will share that with you shortly. Next slide, Sharon. This caregiver-centered care competency framework, which is now published, has 6 domains, and I'm sure they will resonate with you, though it took us many years to get there. One is recognizing the caregiver role. And today, more than ever, we recognize the role that caregivers play in supporting our patients, our clients, our residents, communicating with them in a timely fashion, partnering with them. Now, this term, you're probably more familiar with it because there's an increasing desire and increasing recognition that we need to partner with them in care. Fostering resilience has taken a different meaning. It's not to build a better caregiver. It is to help assess the caregiver needs from their lens, not from our lens, and then help them navigate the health and social systems of care. We also have to take responsibility in providing some of that navigation, particularly for the healthcare system, and then we need to signpost for the other systems of care. And lastly, one major domain is enhancing our culture and context of care. We've got to become good role models ourselves within our healthcare system for caregiver-centered care. Each of these domains explodes into a set of competency indicators. They're anywhere from 3 to 5, and the education that we are developing serves these indicators. Next slide, Sharon. The co-design work has taken us a year. All of last year, we had over 100 people involved, 6 mini groups for each of those domains and the larger multi-stakeholder group. And then we had our research group. It was painstaking. It was a labor of love. And I think when you see the product, it will resonate with you. And I think you'll be quite happy with it as well. But really, co-design, I've become a big believer in it now. It was tough for me to accept it to begin with. Being a physician, we like control. However, having seen the end result, everything I do from now, I have recognized it has to be co-design. Next slide, Sharon. This education now is available. We launched it in November for a test run, which we completed in 3 months. We've had over 500, and I think it's close to 600 people now who've taken it. It has been rated very highly, and we are in the process of summarizing the evaluation and producing a report and publishing it. And we will show you, just to give you a little glimpse of the evaluation today. And it has been recommended now by CFHI as a leading education for healthcare providers in supporting family caregivers in Canada. Next slide, Sharon.
Okay, so this is a taste of the education here.
Charles can't manage on his own now, and they must know it. So why would they leave me sitting in the waiting room? I'm managing most of his care and medications. I'm with him 24/7, yet I'm not important.
Healthcare professionals see so many people in need every day. It can be a challenge to also keep up with their family caregivers. Nevertheless, those caregivers can be our most effective partners in ensuring we have a care plan we can all carry out.
My mom forgot the name of her case manager, if she was ever told, and I can't find it either.
Oh, I'll help you find it, Lacey. I'm sorry that fell through the cracks.
Well, sometimes a case can feel like it's nothing except holes and cracks.
Especially for the caregivers. But on the plus side, there's an army of people like us to help.
Right. A case manager, social worker, physiotherapist.
Rec therapists and healthcare aides?
Yeah, occupational therapist, an LPN or two, and a pharmacist.
Now you see the reason you need case managers.
Yeah, it takes a village, I guess.
So to speak. But no matter what, you always need a caregiver first.
Ah, yes, preach, my friend.
Listen to the caregivers. They have stories. Do you remember the Goodmans? Sally and her husband, Charles?
Sure.
Last week, at one of Charles' appointments, the doc came in and asked Charles what his problem was. But Charles struggled to recall why he was there. Sally was anxious to talk to the doc, but he just scribbled something on Charles' chart.
And then come back and see me in 3 months and we'll find out how you are.
Pat it.
Thank you, Sharon. This education speaks to the key learnings in each of those 6 domains. And you will find that it's foundational. So it's for every healthcare provider. So it could be a physician, RN, LPN, HCA, OT, PT, they can all receive it. And it's designed for all settings. So it could be, you can use it for healthcare providers in acute care, in long-term care, in supportive living, home care, and primary care. And that's why it's foundational. And when we created this education, we had disciplines from all these disciplines, as well as family caregivers, all the settings, professional organization, and training institutions involved. So when you receive this education, every healthcare provider, every healthcare setting, every healthcare education institution, trainees can see themselves and in this training, and they can see it being applicable to them. The evaluations have been fabulous. the qualitative analysis is just remarkable. Never seen anything like this. It's just every person who's taken the education has something positive to say about it. We had a geriatrician say, "I'd like every medical student to take this education." There are so many comments. It just overwhelms me when I see those comments. And then, of course, we also did pre and post evaluation, and this is per person, so it's based on that individual's learning. And we asked them 10 different questions, and in each area there was improvement. Some of those are identified here on this slide, such as identifying family caregivers, feeling more comfortable and confident, communicating with them, partnering and assessing. They felt their knowledge and their comfort and confidence had gone up in all these areas. Next slide, Sharon. So our request to you is please take this education, spread it. There are many opportunities, I know, to provide education. Think broadly. I'm sure there are other people creating education as well. It's not to say this is is better or worse. It's one opportunity you have of well-tested education. Take it. And I hate to see us keep reinventing the wheel. Not that there's too much education that's available to healthcare providers to support family caregivers. There is more and more coming, and we may be able to layer it. But at this moment, this is what we have created, and we'd like you to look at it and please spread it. 2, we are now developing a COVID module to support family caregivers. We are developing, and shortly that will be released in April. Shortly after that, we are developing an advanced level education, which will be a 3-hour workshop for healthcare providers who spend a lot of time with family caregivers. So think of case managers and recreation therapists, social workers, geriatric assessment nurses, psych assessment nurses, and certain cadre of physicians. The list can be quite long. And then finally, in our work we are doing, we are also creating caregiver-centered care champions from within the healthcare system, and we are creating a module for them. So please, if any one of you are interested, we have many partners now from other provinces that have joined us, and they are not only informing the education, they're taking it and they are also spreading it and using it for their settings and services. Next slide, Sharon. I think that brings me to the end, and please don't hesitate to call us if you have any questions or if you'd like any more information, and I'll hand it back to you, Karen.